technical parameters. Now I am going to talk about how we should assess the X-rays. So what is the assessment of situs? Situs means like the heart chambers like atria, how they are oriented with the other structures in the body. In normal condition, that is called situs solitus, on the right side we should have right atrium, right bronchus, IVC and liver, and on the left side we should have left bronchus, gastric fundus and spleen. But sometimes the heart is towards the right side, that is called dextrocardia. So these things happen, or there may be situs inversus, that there is dextrocardia, as well as the abdominal organs are also situated in the reverse way. So the first thing is assessment of the situs. I told you what things should lie on the right side and what things should lie on the left side. Now coming to evaluation of individual structures, I have proposed a scheme where I will move from central structures towards peripheral structures. So first of all, I should see the trachea. The trachea is basically an air-filled tube, and normally it may be slightly on the right side, but usually it's in the midline, and it divides into right and left bronchi, that is called carina, at the level of D5 or 6. D5, 6 level they usually divides, and we should see that the trachea is in the midline. There should not be any soft tissue shadow or any narrowing in the trachea, and coronal diameters in females are 21 millimeter and males are 25 millimeter, although every country and every population has variable proportions, body proportions. So after evaluating the trachea, we should evaluate the heart. Normally 2/3 of the cardiac shadow lies on the left side of the midline, 1/3 on the right side and 2/3 on the left side. So most of the heart is on the left side actually. And to evaluate the size of the heart, we should take a ratio of the diameter of the heart with the largest inner thoracic diameter. I will tell how I will take. And normally the cardiothoracic ratio should be less than 50%. That means the heart should be less than 50% of the inner thoracic diameter. But in athletes or in some individual it may be more than 50%, and in neonates it may be more than 60%. So there are exceptions, but generally the heart should be less than 50% of the inner thoracic diameter. So here how you are going to measure it? So there are two images. We should take the diameter of the heart, and we should take the maximum inner thoracic diameter, and then we should calculate the ratio. The heart should be less than 50%. Now coming to the borders of the heart. On the chest X-ray we don't see individual structures, we just see a shadow of the heart, but by knowledge of the anatomy we know that the right heart border is formed by from above downward is formed by the superior vena cava, and then the right atrium, and sometimes a part of the IVC may form the right heart border. Normally the right heart border is formed by superior vena cava and the right atrium, whereas on the left side it is mainly from above below, it is mainly the aortic arch, then a small area is formed by the pulmonary artery, that is called pulmonary artery segment, then we have left atrial appendage, and then we have left ventricle. So what we see, that the right ventricle don't take form in the border of heart in a PA or AP film. So right heart border is formed by superior vena cava and right atrium, and left heart border is mainly by aortic arch, pulmonary artery, left atrial appendage and left ventricle. But on a lateral view, the anterior-most chamber is formed by the right ventricle. So this thing has got implications in cases of individual chamber enlargement. This knowledge is important actually. So in the lateral view you see the right ventricle is the anterior-most chamber of the heart, and the left atrium is the posterior-most chamber of the heart. Now coming to the mediastinum. Mediastinum is basically the structures which lie between the two lungs. The structures which lie between the two lungs are known as mediastinal structures. There are two classifications. One is the anatomical classification, and one is the Felsen classification, which is followed by radiologists. In an anatomical classification, the mediastinum is divided into 4 parts. One is the part of the mediastinum above the heart is known as superior mediastinum. The part of the mediastinum which lie anterior to the heart is the anterior mediastinum. The heart lies in the middle mediastinum, and things behind the heart are in the posterior mediastinum. But this is an anatomical division. What we follow, or generally many radiologists follow, a classification defined by Felsen. Felsen drives 2 lines on a lateral chest X-ray. The anterior line is derived anterior to the trachea and posterior to the heart, and structures lie anterior to this line are classified into anterior mediastinum. So heart, according to the Felsen's classification, heart lies into the anterior mediastinum. Now, to define the middle mediastinum, a second line is drawn just 1 centimeter behind the anterior vertebral margins. As you can see in the slide, the second line has been drawn 1 centimeter behind the anterior vertebral margin. So the structures which lie between these 2 lines are lie in the middle mediastinum, and the structures which are behind the second line lie in the posterior mediastinum. So according to the Felsen, the posterior mediastinum is a very small compartment, and basically only some paravertebral structures lie in the posterior mediastinum. Heart lies in the anterior mediastinum, like trachea, bronchi and esophagus. Mostly these things lie in the middle mediastinum. So this is a classification by the Felsen. Now coming to the diaphragm, we have 2 diaphragms, right and left. We sometimes call them hemidiaphragms. And diaphragm is basically a muscular-tendinous structure. There is a central tendon surrounded by striated muscle sheets. Normally the right diaphragm is slightly higher than the left diaphragm. The right diaphragm is 1.5 to 2.5 centimeter higher than the left diaphragm. Generally in 90% of the cases this is true. But in 9% of the cases, the left diaphragm is same level as of the right diaphragm. And sometime in 1 to 3% of the cases, the left diaphragm may be slightly higher. So generally the right diaphragm is higher, but there is range. If one diaphragm is more than 3 centimeter higher than the other diaphragm, then we label this as a raised diaphragm. If one diaphragm is higher than 3 centimeter than the other diaphragm, then we label this as a raised diaphragm. There may be many causes like eventration, diaphragmatic hernia, some subdiaphragmatic pathology. So there are a lot of conditions, and in this image, the slide, the image shows raised left diaphragm. The left diaphragm in this case is higher than 3 centimeter compared to the right diaphragm. So this is a case of left diaphragm. We have to work up further to know the cause of this. And normally the diaphragms during inspiration and expiration move about 1.5 to 2.5 centimeter. And this is also useful when we evaluate cases of diaphragmatic palsy. Then sometimes we take inspiration or expiration view to compare the movement of the diaphragm. So these information are important